Thank you so much, John. Welcome, Dr. Trammell. How are you?
Well, Crystal, how are you?
I am blessed. I am blessed. Please, by all means, introduce the audience to our esteemed guest today.
Thank you. Hey, everyone. Well, it is my pleasure to introduce to you Dr. Jasmin Nwachokor. If I said that correctly, Doc. Dr. Nwachokor is a urogynecologist practicing at Emory Johns Creek. So she's known for combining her surgical expertise with compassion. And she works hard to deliver a patient centered approach to her care. She believes in treating every person, every patient with respect, kindness, and the same dedication that she would give a close friend or family member. Dr. Watchakor is known for taking her time. She's known for listening and making sure that every woman that she treats feels heard, valued, and confident in their treatment plan. I don't think we can ask for a better person to come and talk to us today. So, with that being said, Dr. Watchakor, please take it away.
Okay, thank you so much. Thanks for inviting me to come talk with you guys today. I'm gonna share my screen here and then we can get started. Can you guys see that okay?
Yes, ma'am. It looks
Okay,
great.
perfect. So today my talk is going to be on pelvic organ prolapse, basically to figure out what's going on down there. I know a lot of people come to my office and they're like, well, I feel this bulge. I feel someone told me I had a prolapse. So let's talk about what it is and, why it happens and what we can do about it. So I am a urogynecologist. And so oftentimes when patients come to my office, they're like, I didn't even know that existed, or what do you do? So at first, I wanted to show you guys kind of the process. So a urogynecologist is someone who's finished med school and then can either go to an OB/GYN, which is what I do, or you can go through a urology residency. And then once you complete that, you further specialize in urogynecology. And urogynecology really is talking about things like urinary incontinence, prolapse, pelvic health type of things, specifically for women. So um, I know this presentation reaches a lot of people nationwide. So if this problem happens to be something that you have, feel free to Google and search and figure out who's a good urogynecologist or who's a close urogynecologist in this area. So, and talking about pelvic organ prolapse, the first thing to review is just kind of normal anatomy. This is a lady here who, cartoon figure, who's cut in half down the middle, who has good support, no prolapse, nothing is shifting down. This is the front of her body with her pubic bone being right here. And then this is the back of her body with her spine being right here. Now, we all have 3 holes down below for women. So the first one is the pee hole that goes up to the bladder. Another name for that is the urethra. Then we have the vagina that goes up to the cervix and the uterus for people who have not had a hysterectomy. And then the back, there's the rectum. So when we talk about prolapse, we're really talking about what wall of the vagina is coming down. So is it the front wall, the wall closest to the bladder, the top or the apex, or the back wall, the posterior wall? So there's a handful of different types of prolapses that can occur. Like I mentioned, we really want to identify where the predominant area is. So that's either the bladder area that's coming down, which sometimes people call that a cystocele. It could be the rectal area coming down, which is also called a rectocele. The top wall of the uterus or cervix could be the presenting part coming down. Or if someone's had a hysterectomy, the vagina itself can prolapse. And you can see these pictures down here with the bladder on this one being the predominant thing coming down, the rectum being the predominant thing coming down on this one, the uterus, and then the vaginal vault. The symptoms that can occur with pelvic organ prolapse, I bolded the most common one, which is bulging, and heaviness, feeling like you're either sitting on a ball or something's coming out. Sometimes patients can have trouble emptying their bladder or having bowel movements. Sometimes patients will come to me and say, well, in order to empty my bladder or to fully feel like I've had a really good bowel movement, I have to stick my finger inside my vagina and press on something so it can empty all the way. If that's something that you have to do, then chances are you may be suffering from a pelvic organ prolapse. And occasionally, patients have discomfort with intercourse. So the next question is who gets pelvic organ prolapse? And surprisingly, up to 50% of women who present to a gynecologist's office just for regular annual checkup will have some form of pelvic organ prolapse. Does that make it normal? No, but it does make it pretty common. Other risk factors that patients can have are if you've been pregnant before, specifically with vaginal deliveries. If you've had C-sections, you're still at risk for pelvic organ prolapse, but it's a lot lower risk than people who've had vaginal deliveries. In addition to that, our older adults and aging population are more at risk for pelvic organ prolapse, specifically menopausal women, because there's no longer that estrogen around. We'll find that estrogen can be really helpful, specifically vaginal estrogen in building the collagen production in the vagina. Genetics can also play a role. So if the female members of your family also had issues with pelvic organ prolapse, mom, sisters, aunts, grandmother, that can also play a role. Another thing is chronic straining. So any patients who are smokers or who have had chronic coughs or suffer from chronic constipation, that constant bearing down and that increased abdominal pressure can really take a toll on someone's pelvic floor. Another thing that we want to think about is patients who are obese. Occasionally, the extra tissue in the abdominal area can also put a strain on the pelvic floor and contribute to pelvic organ prolapse. So as you can see, it's a very common problem that oftentimes people either don't know that they have it or have it and just kind of ignore it because it's part of the normal aging process. And we can say that that's not necessarily the case. So why do people get pelvic organ prolapse? It's caused by the weakening or disruption of pelvic muscles and connective tissues. Basically, the pelvic organs are going downward into the vagina, like the pictures that I showed previously. So what can we do about it, right? So there's a ton of things in the field of urogynecology. Oftentimes, the problems we deal with aren't life-threatening, but can truly impact quality of life. Can impact the way people, interact with their family, their friends. Are they always looking for a restroom? Are they afraid to pick up items for gardening or groceries and things like that? So it's good to kind of hear about what treatment options are available. The first thing really is you don't have to do anything. As long as it's not bothering you, it's not precluding you from doing the normal activities that you love to do, then we don't have to do anything. A handful of patients come to my office and they say, well, I was just doing my annual exam and someone told me I had a prolapse, so that's why I'm here. Well, if it's not bothering you, you're urinating okay, you're having bowel movements okay, you're living your life, we really don't have to do anything about it. It doesn't increase your risk for cancer or any serious ailments. We do like to keep an eye and make sure you empty your bladder, though. That's the biggest thing. If we notice that you're not emptying your bladder well, then we'll say, yeah, maybe pursuing some form of treatment, either conservative or surgical, would be a good idea. The next option is pelvic floor physical therapy. And oftentimes patients are like, what is pelvic floor physical therapy? Or, I can do Kegels at home and, will that really be helpful? And to be honest, pelvic floor physical therapy is a great option for patients whose prolapse isn't progressed or has not progressed and isn't that advanced. So maybe it doesn't come out all the way, or maybe it only comes out certain times when you're on your feet all day. Pelvic organ prolapse can happen in a range of stages, but physical therapy can be helpful for prolapse. It can also be helpful for incontinence, pelvic pain, pain during intercourse, constipation, if you have low back pain, hip pain. So it's kind of the big encompassing treatment option that a lot of patients can benefit from. And it doesn't always mean just Kegel exercises. It may incorporate Kegel exercises to build strength in your pelvis, but sometimes Kegel exercises aren't the only thing that needs to happen. As you can see here, there's the picture and your pelvic floor muscles. This represents kind of the sum of your pelvic floor muscles because there's a ton of them in that area. And as you can see, your bladder sits on top of it, and your urethra, the pee hole, goes through it, the vagina, and the rectum. So as you can imagine, there are a lot of things that physical therapy can help. As you can see here, it also connects to your spine. So if patients who have low back issues, it connects to your hips. So if there's any hip issues, and your abdominal core as well. So usually with physical therapy, we tell patients to find a physical therapist, a pelvic floor specifically, physical therapist that's had additional training, because oftentimes patients do, when they're in pelvic floor physical therapy, the therapist does go inside the vagina during those visits. Not all the time, but sometimes. And so you want to make sure you're comfortable and that your therapist has had additional training to show you how to build the strength of your pelvic floor and to stabilize the other areas of your body. Usually physical therapy is once a week for around 8 to 12 weeks, but oftentimes that shifts depending on what problems are going on, how you're progressing in physical therapy, and how often you're able to incorporate the homework they send you home with. So oftentimes we do talk about Kegel exercises. Again, sometimes they're really beneficial for patients, sometimes they're not, and other exercises need to be done. But one of the things that can be very helpful in just kind of maintaining the pelvic floor strength is doing Kegel exercises daily. So whether you're waking up in the morning, there's commercials on TV, you're sitting on a bus, you're sitting at a stoplight, it's easy for you to take a moment and just kind of contract your pelvic floor. What you're going to do for most patients, I tell them it's almost like picking up a Kleenex or a paper towel with your vagina. I know it sounds weird, but oftentimes that's the idea that needs to be in someone's mind to properly perform a Kegel exercise. There's also this diagram here that bends when you draw up your pelvic floor muscles, it should feel like you're trying to hold on to your pee. And so doing that, holding it for 3 seconds and releasing can be a really good exercise if you're not close to a pelvic floor physical therapist or don't have access to one. So the next option is a pessary. Now, don't let this picture on the right side scare you because there's a ton of different pessary options. Oftentimes we use the same kind of models, but there are a ton of different shapes and sizes. Pessaries are plastic or silicone round rings that are flexible. Oftentimes you can manage it yourself with the guidance of a urogynecologist. And basically, it's like a bra for the vagina. So you put it in, it lifts everything up, it relieves the discomfort and the pressure of the prolapse. Oftentimes, patients can wear it more than one day at a time. If you're managing it yourself, you would take it out a handful of times a week, clean it, leave it out over the night, and put it back in the next day. I find that this is really helpful in patients who say, oh, well, maybe surgery is not something I want to do, but I want a little bit, of relief for me to do my normal day-to-day activities. And oftentimes patients will use this until it's time for surgery, or they'll use this indefinitely as a treatment option for pelvic organ prolapse. So these are really good options. Oftentimes patients are intimidated by the fact that they have to manage it themselves. And if that's the case, oftentimes the urogynecologist can see patients to manage it where they don't have to manage it themselves, or we teach you how to manage it. And it's surprisingly a lot simpler than what you think it is. So it's a very good option for patients who, again, want a more conservative treatment option. The next thing that we talk about for treatment options is lifestyle modification, specifically treating constipation. I'm always surprised by how many patients have constipation, whether that's because of their diet, the medications that they're on, the lifestyle, just a ton of a ton of reasons why someone can have constipation, and you don't have to suffer from it. So oftentimes I tell patients a daily fiber supplementation can help, whether that's Metamucil or Benefiber powder. There are the gummy, fiber gummies that are out there and fiber pills that are a little bit easier to take. But with those ones, we want to make sure you're taking enough. So it's very important to read the back of the bottle to make sure you're incorporating enough. Because oftentimes with the fiber gummies or the pills, you're needing to take at least 2 to 4 of them for you to meet your daily kind of requirement of fiber. Another thing to consider is Miralax. Sounds like a laxative. It's not quite. So it's something that you can also take every day along with these fiber supplementations. And then the other picture here, I find that sometimes recommending a squatty potty can be helpful too, because it allows the stool to evacuate from the rectum a little bit easier based on the positioning of your legs. So all good things. As you can imagine, if you're bearing down a lot with constipation, it can affect your pelvic floor. It can affect the stress that's put on your pelvic organs and can really influence whether or not you develop pelvic organ prolapse. The next section of treatment options include things like surgery. Again, with surgery for pelvic organ prolapse, it's very, very, very patient dependent. There's so many options that we can talk to patients about when it comes to surgical management of pelvic organ prolapse. It's very much shared decision making. So the good thing about surgery when it comes to pelvic organ prolapse is I would say 95% of the time, patients can go home the same day, which is great because recovery at home is a lot better than in the hospital when it comes to getting back on your feet, getting back to your routine. There's less traffic coming in and out of your room compared to the hospital. Another thing is there's options as the route of how we're going to fix things. We can do all incisions inside the vagina. We can consider doing it laparoscopically or using the robot to make it minimally invasive for our patients. Then there's often the discussion of do we use mesh, which is quite different than the one that got pulled from the market, but that's a whole nother conversation that we can talk about. But mesh can be helpful in suspending the uterus, or some patients feel more comfortable with using surgical thread or suture and tying everything up to their own tissue. Again, there's varying degrees on the efficacy and kind of where your prolapse starts from and how much improvement we're trying to get. Another thing is oftentimes patients, who are in menopause or perimenopause are oftentimes comfortable with moving forward with the hysterectomy. It does add a little bit of time to surgery, but it can be helpful when it comes to suspending the uterus. Some patients are very much tied to their hysterectomy, although it's no longer needed for reproductive health, and don't want to undergo a hysterectomy. And so we can also talk about things where we don't do a hysterectomy, but we can suspend the prolapse a little bit higher. And so you would have less symptoms of the vaginal bulge sensation, that sensation that there's pressure, that you're sitting on something. So there's so much flexibility with surgical management options for prolapse. Again, it's a very individualized conversation to have with your provider if you're thinking about surgery. And everyone is a little bit different when it comes to the recovery process after. Oftentimes, it's a 6 weeks recovery. So, really, you're kind of getting back to your normal life, but things are just a little bit slow when it comes to walking around, going upstairs, things like that. We say no heavy lifting, nothing more than 15 pounds, nothing inside the vagina, so no intercourse, and not submerging in water. So no pools, baths, beaches, or tubs. You can shower like normal, but we want some of those incisions inside the vagina to heal before you get in water. So again, a number of options when it comes to surgical treatment for pelvic organ prolapse. And the next slide talks a little bit more about kind of the different treatment options and when you can choose one versus the other. So really the defining kind of division up top here is, do you want to still have the ability to have penetrative intercourse in the future? If you're like, no, I don't even care, I don't want that anymore, then really narrowing and closing the vagina is the best surgical option if you're okay with that. It's 99% effective. It's a very quick procedure. We don't take out the uterus. But some patients have partners or looking to have partners in the future, or penetrative intercourse is very important to them. And, we respect that. And so if that's the case, then really reconstructive options are really what we're thinking of for you. That would still allow for penetrative intercourse. And then again, we have the two types of options. One where we're using mesh, which is very strong and can lift everything up. And then the other option is just using your own tissue. So again, so many options to discuss with a provider about treatment options if you're interested in surgery. So I know that was a very kind of short presentation, but hopefully it's got the highlights of everything that introduce you to the topic of pelvic organ prolapse and kind of what's going on down there. If patients come to me, I definitely talk to them about their goals, their quality of life, what their activity is in life, kind of activity level. Are they active? Are they playing golf? Are they playing pickleball? Are they more, just hanging out with the grandkids and more and less active? I think that oftentimes play into part of what treatment options patients can pursue. Again, surgery is not always the answer for a lot of patients. Maybe there's some other comorbidities that could be going on, and or maybe recovery and just the time of the year is not right for surgery. Again, there's a ton of options. I really do think, just my hope for this talk was to inspire conversation, whether that's you asking questions here or you being inspired to look up some of this stuff and present it to your provider when you go see them. If this is something that you're suffering from, you don't have to suffer from it. It's common, but it's not normal, and we can always find solutions for you. So I'll open the floor to any questions that you guys may have, and we can go from there.
All right, so there are a few questions.
Okay.
One would like to know if insurance covers pelvic floor therapy.
That is a great question. It depends on your insurance, unfortunately. With pelvic floor physical therapy, oftentimes, if you can find a provider in network, then it will be covered. Now, there's a copay, oftentimes, depending on your insurance. There are a lot of pelvic floor physical therapists who are trained in academic institutions. So if your insurance is covered at an academic institution like Emory, we have a lot of pelvic floor physical therapy locations, and insurance is taken. Now, if you are a patient who is more in a suburban or rural area, finding a pelvic floor physical therapist who takes public insurance might be a little bit harder, because oftentimes in those areas, it's a private practice pelvic floor physical therapist. So it will take a little bit of kind of searching to find the right physical therapist that your insurance take. But most insurance do take it. You just kind of have to find and make sure that the location is in network.
Okay. And someone asked, and they prefaced it with, this may be a silly or inappropriate question. It's not silly, it's not inappropriate at all.
Yeah,
All questions are great questions,
I
okay?
agree.
So they ask, how would using a pessary affect intimate relations?
Oh, good question. So when I talk to patients about pessaries and kind of teaching them on how to manage it and when to take it in and out, oftentimes I tell patients to take it out for intercourse, because the amount of space in the vagina is fairly limited, but also it oftentimes is more comfortable for patients if the pessary is taken out before you have intercourse. Now, some patients are comfortable with having intercourse with the pessary in place, and their partner is as well. So that's definitely a conversation that I would say be open with your partner. Say, discuss your pelvic floor health concerns. Mention that you do have a pessary. You can try having intercourse with the pessary in place, but oftentimes I do feel like most patients decide to take it out prior to being sexually active.
Okay. So there are two similar questions next.
Okay.
The one, does a hysterectomy lead to vaginal prolapse? And someone else also asked if a hysterectomy can result in another type of prolapse.
Good
Is
question.
there a relationship between
Yes, that's a
hysterectomy and
great
prolapse?
question. There is yes and no. So if someone undergoes a hysterectomy, and there's not a suspension procedure performed at the same time, it can increase your risk of pelvic organ prolapse. I would say probably over 50% of hysterectomies are done without a suspension procedure. So most of the time, I would say a hysterectomy does increase your risk if you've had one before. Now, when it comes to doing the repair, so say you have prolapse already and you have a hysterectomy to fix the prolapse in addition to a suspension procedure, then no, that's not the same. It doesn't make the recurrence of prolapse higher. So again, if you've had a hysterectomy before and didn't have prolapse, it does increase your risk a little bit of having prolapse in the future if there wasn't a suspension procedure done at the same time. But if you come to a doctor's office with prolapse and you have a uterus, whether or not they do a hysterectomy to fix the prolapse has no bearing on whether or not you will redevelop it in the future. Hopefully that was clear enough.
Let's dig into that a little bit more.
Mhm.
Um, so one, what do you mean by suspension procedure? Can you
Good
clarify that?
question. Yeah, yeah. So oftentimes, when you remove the uterus, the support that the uterus has that kind of it allows it to be suspended up is removed when someone does a hysterectomy. So the way to incorporate that back as they're closing the top of the vagina after a hysterectomy at the time of the procedure is to incorporate some of the ligaments that will allow the vagina to be supported. And so, if that is incorporated at the time of closure, that decreases your risk of prolapse. So, in a suspension procedure, would be called like a incorporating the uterosacral ligaments with the
Mhm.
closure, or doing a caudoplasty. Those words kind of get thrown out. Again, oftentimes most people don't have this performed, but it can be in general gynecologists who've been trained in it. So, yeah,
So it's like pulling things up, right? So that they
yes,
won't sag later on.
like
Okay.
yes,
Now,
yes.
sometimes a hysterectomy is done without what's called an oophorectomy or removing the ovaries, right?
Mhm,
So when you take the ovaries out, there's less estrogen. At the
mhm.
start of your talk, you mentioned estrogen and collagen production, basically a protein that helps maintain the structure of the pelvic floor, right?
Correct.
So is there a difference in prolapse after a hysterectomy alone versus when the ovaries are removed as well?
That is a great question. So there is not specific data out there to really answer it, but I will say this. We know that even after someone has entered menopause, which is around the age of 51, 52 on average, we know that from that time of someone entering menopause until the age of 65, that the ovaries can still provide some benefit. It may not be producing a lot of estrogen to the point where you'd be having a menstrual cycle, obviously, or significantly change things, but it can provide bone health, cardiac health, things like that. So, if for some reason, so I don't typically do remove the ovaries unless I have to after the age of 65. So, if someone has had the ovaries removed prior to the age of 65, it can increase your risk a little bit of developing pelvic organ prolapse. And oftentimes, patients will then be started on a vaginal estrogen cream which is very different from systemic hormones. Vaginal estrogen stays locally, and that local estrogen can improve the collagen and the microbiome of the vagina and the bladder. So that can be helpful.
Right. And someone asked, does external estrogen cream, does it help prolapse? In particular,
Yes, it
prolapse stage
can.
1. So it can, okay.
It can, yes. Now it's not it. I like to think of it as a miracle drug, not drug, but cream. But it's not a miracle cream because it won't. If the prolapse is hanging out a lot, it's not going to make it go all the way up. It needs a little, the body needs a little bit more help than vaginal estrogen. But if it's early stages, stage one, the bulge isn't coming past the labia, you're not having to push anything in, it can be helpful for that in increasing the collagen production.
Okay. Does heavy lifting increase the risk of pelvic prolapse?
I get that one often. And the answer is, again, a little bit mixed because there are a ton of women who imagine, the power lifters in the Olympics, right? We don't often see those women in our clinics with prolapse. So strenuous, heavy lifting regularly may contribute a little bit to it, but I think the strenuous, like coughing down if you're a smoker or chronic bronchitis, or the pushing down with constipation causes more trauma to the pelvic floor than heavy lifting. So if you do the occasional heavy lifting, that's fine. Don't change your life in regards to that. If you work out and lift weights, resistance training, don't change your life for that. But if you notice that every time you're constipated or coughing or have allergies or asthma or a smoker, then those are the things we need to address more than the amount of heavy lifting that a patient is doing.
Okay. See, does prolapse cause incontinence? And they didn't specify whether it's bladder or stool. And are there other causes of incontinence? So does prolapse cause incontinence? And are there other causes of incontinence?
Good question. Oh, these are such good questions. Thanks for asking, everyone. So prolapse can, how do I say this? It depends on the type of incontinence when it comes to urinary incontinence. So there's stress incontinence, meaning leakage with coughing, laughing, sneezing. And then there's urge incontinence. I get the urge to go to the bathroom and I can't quite make it. There is some correlation with pelvic organ prolapse in the gotta go, can't make it type of leakage. Oftentimes, that is because patients can sometimes don't empty their bladder well when they have prolapse. So, as you can imagine, if you have a bucket of water and you can only empty half of it, it's easier for you to fill up again. And so that's kind of what happens if someone has prolapse. Now, when it comes to fecal incontinence, there can be a correlation, and it's not necessarily the fact that the prolapse is there. It's more so the fact of like the pelvic floor strength and coordination of strength with the pelvic floor. Because remember in that picture, there's the pelvic floor, and then the bladder goes through it, the vagina goes through it, and then the rectum goes through it. So if there's any issues with the pelvic floor, that can very much affect all three of those organs.
Okay. So with prolapse, how long before pain and bleeding can occur?
There should not be any pain or bleeding with prolapse. So if you are having pain or bleeding, then you should go in and see your gynecologist or urogynecologist to address that. The bleeding could come from, it could be uterine bleeding. It could be because the vagina is dry, which we call atrophy, because there's not estrogen around anymore. But pain, really, if you're having a symptom of pain, not just pressure, but pain, whether that's walking around with intercourse, that truly is more pelvic floor related. And treatment when it comes to the pelvic organ prolapse, if it's not encompassing pelvic floor physical therapy, it may not address the pain. It will address the bulge, but it may not address the pain. And that's why we really want to sift out and figure out what is a part of the patient's profile.
So when it comes to treatment, is the pessary a temporizing measure, or basically will people eventually need surgery?
There's a lot of people. I have a range of patients who will come in and will use pessaries in various ways. So pessaries can also be used for stress incontinence. So I have patients who come in who say, you know what, I don't leak. The only time I notice my pessary is when I go on my, morning 2 mile walk, and I need something because I like doing my walk and it's affecting my life. And so if that's the case, we'll talk about a pessary. They can use it only at the time of their walks, or they could use it all day. So you can pick and choose once you know how to use the pessary. And then some patients use it all the time, no matter what, because they don't want surgery. So it's not always that patients will kind of graduate into surgery. We can manage basically almost any type of prolapse with a pessary if we wanted to. There's different shapes and sizes. We might be changing the models and things like that, but we can manage a prolapse long term with the pessary. It doesn't always mean transitioning to surgery.
Okay, let's see. After a hysterectomy, is it okay to push heavy objects?
Push or lift? Does it say push?
In particular, push.
Push. Yeah, you can still still live your life. That's what I tell patients. If you know, it's a good question because oftentimes patients are like, do I need to change my life because of this? And the answer truly is no.
Hmm.
If lawn mow, push, that's the first thing that comes to mind when I think of pushing something, but there may be other things coming to mind, strollers, I don't know, where you're pushing stuff. That is perfectly fine. You're not going to hurt anything, you're not going to mess up anything. Prolapse comes from a long-term repetitive insults to the pelvic floor or genetics or collagen issues. So keep living your life, keep having sex if that's what you want to do. That's not going to change anything. It's not going to make it worse. Now, if there's pain and bleeding, again, like we talked about, that's something else, and we need to address that and have that looked at. But keep walking, keep lifting, keep pushing, keep doing all those things that really allow you to live your life.
So I think this may be the person trying to clarify. Are leg pushes on a weight machine safe?
Oh, okay. Yes.
The
Yes.
pelvic
Please
area.
still do that.
Okay.
Yes.
So
The other
that
thing, see, I was thinking about lawn mowing and strollers. I don't know, that's where my mind went, but thank you for clarifying. So yes, still please do those things. The other thing is you want to make sure you're engaging your core and your back muscles as you do that. Not, I mean, I know you still want to isolate the muscles to move and do like leg presses. You can still do that, but make sure you're engaging all of those other supportive muscles so you're not straining one more than the other.
does holding urine increase the risk of prolapse?
I'm sorry, I didn't hear that.
Does holding urine,
Oh,
basically, like if you have to go to the
yeah.
bathroom and you're
Yeah.
holding it, does that increase your chance of having prolapse?
There is no studies that show that there's an increased risk. Now, I have seen patients, there's certain professions, doctors, nurses, teachers, and other professions that where you're on your feet and you can't really take the breaks that you want to go use the restroom. So that can be associated with more urgent incontinence, like I got to go to the bathroom and I can't quite make it in the future, but not necessarily with prolapse.
Okay. And someone has, it's okay. They said they were a little bit late, perfectly fine.
Yeah.
How can you tell if you had a prolapse? I think this would be a great way to kind of wrap up our Q&A. So
Okay.
how can you tell if you've had a prolapse? They had, I guess, a hysterectomy, but my ovaries were left behind.
Okay. So whether or not your ovaries are left in place or not has little correlation with prolapse. Prolapse more is that sensation of something is coming out of my vagina, or I feel like I'm sitting on a golf ball or a grapefruit or an orange, like something, there's just pressure between my legs, something's coming out, and it feels like I feel uncomfortable because of it. So that's really the defining symptom of prolapse. This vaginal bulge, whether you feel it or see it with wiping, when you're in the shower, whatever it is, you're told on exam from a provider, it's visually the bulge and the dropping of pelvic organs into the vagina.
Dr.
Yeah,
Nwachokor, thank you so much. This has
no
been
problem.
very educational and enlightening.